Let's start with a really simple case. 64-year-old lady with long-standing hypertension and 2-year history of angina comes to see you for a routine visit and refill of her meds. She's a current non-smoker, her BMI is 33, and you're treating her with the usual cocktail of metoprolol, benrofluozide, aspirin, quinapril, and simvastatin. So you've recently been to an update on rheumatology, so you check her uric acid along with her routine bloods. And the uric acid's 0.49. Apart from a creatinine of 112, the rest of her bloods are normal. So do you, and I'd like you to just put up your hand for which of these 4 options you're going to do, and you do need to put up your hand for one of the options. If you've got a 5th option, sorry, I haven't got that. So do you stop her aspirin? Switch her simvastatin to atorvastatin. So actually, atorvastatin is one of those drugs that has the incidental benefit of lowering your uric acid a little bit. Observe. Stop her benrofluozide. A couple of you didn't raise your hand. It's distressing. Okay, so you've stopped her benrofluozide, which in everyday practice is probably the greatest increaser of uric acid. You've increased the quinapril because you've stopped the benrofluozide. You switched to atorvastatin and got her to drink more water. And so you repeat her uric acid, and it's 0.55. Now, obviously, it's not 0.55, but just go with the story. So do you refer to rheumatology? Good. Get her to lose weight. 1 for losing weight. Start allopurinol. 2 halves. Observe. And again, distressingly, there are a few people who have not put up their hands. Okay. So let's just look at their weight loss quickly. There was a New England Journal meta-analysis last year that looked at all the studies on this subject, and they found 10 that were of sufficient quality to analyze, and that's a box plot of those 10 studies. Weight loss in 5 kilograms down the bottom, and in micromoles per liter, so just divide by 1,000, is uric acid up the y-axis. That horizontal line is no change in your uric acid. So obviously there were a few studies that showed virtually no change, and then 4 or 5 that showed a change. So there's a whole lot of data in there. Just for treating your patients, the bottom line is that if you have a greater than 10 kilogram weight loss, you've got a 3 times greater chance of achieving your target uric acid, which is 0.36. Yes. Less than 0.36. Yes. And to get a significant change, and the studies used slightly different significant changes, you need to lose more than 7 kilograms. Okay, so that's what you get. The situation that you're going to be using this is in patients who say to you, what can I do naturally? Okay, I don't want to take medications for my uric acid. Okay, so lose more than 10 kilograms. Interestingly, with rapid weight loss, either in starvation or after bariatric surgery, you get an increase in your uric acid and risk of getting gout, which starts about 2 weeks after surgery. And you can, it settles down eventually. But you can see that in these studies, they were losing around 30 kilograms of weight. So it's pretty massive weight loss there. And that was surgery. So the question I want you to think about in this case is, why would you lower uric acid and when? Obviously, it's a talk on gout, so prevention of gout is number 1. But we know that only 20% of people with hyperuricaemia will develop gout. So when do we do that? And the graph on the left shows you uric acid, again in micromoles per liter along the x-axis, and the annual incidence of gout. So this is in asymptomatic patients up to this stage, the annual incidence of gout with the different uric acid levels. So you can see that right up to 0.48 millimoles per liter. I will always say millimoles per liter when I talk about uric acid. You've got a risk of getting gout in the next 12 months, but it's just less than 1%. So you're probably not going to want to take any medication every day of your life to prevent a 1% risk. But 0.48 is one of those numbers that you remember because that's the inflection point where your risk starts going up quite steeply. Although, even if you look at 0.52, you've only got about a 5% risk of getting gout in the next 12 months. And of course, another 5% in the next 12 months, and so on. So, cardiovascular disease. When I was younger, people used to argue all the time about whether gout was a significant factor in cardiovascular disease or just went along with it. We now know that it is definitely an independent risk factor for coronary artery disease, but there's contradictory evidence as to whether treating it will help your coronary artery disease at all. There is a nice study looking at an insurance company population in the States where they didn't study the patients, but they looked at everybody who was being prescribed urate lowering therapy and got, I think, about 3,000 patients, matched them for age, disease, and sex, and then followed up for 2 years. And those who were being prescribed uric acid lowering therapy, never mind what their uric acid actually was, had lower incidence, a significantly lower incidence of acute coronary events. So that's a little teaser there, but there are also several clinical studies that don't show an effect. Hypertension, there's a small but very nice study where they looked at patients who teenagers with new onset hypertension, so kind of small study, and did a double-blind placebo-controlled study treating them with allopurinol or placebo. And allopurinol in that group is actually quite an effective antihypertensive. But the Cochrane collaboration have looked at it, and in their review they only had 3 studies that were of sufficient quality. The one with the teenagers and the other 2 were adult studies, and they said there was no significant effect. So maybe in adults you have enough microvascular changes in the kidney so that lowering the uric acid no longer has any effect. Urolithiasis, if you look at the urology literature, they will say you alkalinize and drink lots of water, and then after many years, if that hasn't worked, you use allopurinol. If you look at the rheumatology literature, they say jump in there with the xanthine oxidase inhibitors. Obviously, you're going to use the xanthine oxidase inhibitors and not uricus urix. And interestingly, allopurinol reduces uric acid calculi, but also calcium-containing calculi if the patient has hyperuricemia. And then renal disease. So you'll know about the tumor lysis syndrome, which doesn't occur anymore because everybody knows about it and prevents it. There is a rare familial hyperuricemia where they get renal failure as well, and controlling the uric acid level doesn't help the renal failure. But the big thing is our common patient with a bit of renal impairment and a high uric acid. So on the left there you can see massive precipitation of uric acid crystals in the medulla and papilla, and obviously in that patient, and that is a post-mortem view of that patient, the uric acid is causing his renal failure. However, we can't biopsy everybody with raised creatinine and uric acid. And so there's this ongoing argument about whether the uric acid, the hyperuricemia, is causing the renal failure, or it's just there because the patient's got renal failure. And we know that your uric acid goes up with impaired renal function. So what I've traditionally done is to treat patients with a uric acid of 0.6 or greater to lower their uric acid and protect their kidneys. And I just do that because I believe. Recently, I've actually lowered that to 0.55, and that's as a result of my treating patients with gout and seeing improvement in their renal function at lower levels than 0.6. I'm currently collecting some data to have a look and see whether that is a useful thing, but I can't give you that data today. So that's what I do. People on the other side of the argument, the non-believers, say, well, you should wait until you've got an inappropriately high uric acid for that level of renal dysfunction. And so I've just included the levels that are suggested here if you want to take that approach, and I don't. On the left, these are both tophi in kidney biopsies. That one has been stained with or fixed with formalin, and so the uric acid is washed out, and this one with alcohol, so the uric acid stains nicely. So you get these tophi in the kidney that are surrounded by the very low-grade inflammation, and that slowly damages kidney. Okay, so moving on to risk factors for having a high uric acid. Genetics is obviously important, and you've got the rare single gene abnormalities. You'll all remember Lesh Nayan from medical school, and I'd be fascinated to hear if anybody's ever seen one. You actually can get lesser levels of HPRT dysfunction that are not associated with the severe psychiatric and mental changes that you remember from Lesh Nayan. But these are so rare, I'm not going to talk about them. Just if you've got somebody with severe hyperuricemia under the age of 20, you might want to refer them to your local genetics service. Just to give you a flavor of how genetics works, this was a very nice study about 20 years ago now, where some American researchers went and found families of Chinese and Filipino immigrants and did a quite extensive health survey on them, including measuring their uric acid, and then went back to their villages of origin in the Philippines and China, found family members and did the same survey there. And not surprisingly, the guys in the States with the same genetics had much greater level of obesity, hypertension, and raised uric acid. So it's always an interplay between your genetics and your diet. For people like us, it's been calculated that our genetics contribute 40% to our uric acid level, and the rest is predicated by what we eat. So I just mentioned URAT1, which is a uric acid transporter. You know that we reabsorb 90% of filtered uric acid from the renal tubules, and URAT1 is one of those enzymes that brings uric acid back into our body, and if that's particularly functional, then we're going to end up with a slightly higher uric acid level. And there are several of those enzymes and different functionalities in them. I just mentioned that because currently there is some research in New Zealand looking to see if that's a factor in some Maori populations. We don't have to know that. All we have to know is that Maori and Pacific Island people have higher uric acid levels and have a higher risk of getting gout. And of course, men, we get everything, so yeah, our risk is greater as well. Our risk of gout is greater not because we drink beer, But because our uric acid goes up when we're about 14 or 15, continues to rise slowly till we're about 25 and we're fully bulked up, and will then remain high for another 15, 20 years until we've accumulated enough to get gout. So with women, their uric acid goes up after the menopause, and so that's why you see 75-year-old ladies with hypertension getting their first attack of gout. I'm figuring you all know about diet and uric acid. The thing that has become apparent in the last 5 to 10 years is the role that sugar and sugar-sweetened drinks, including the fructose sweetening in everything that's in a packet, plays in increasing your uric acid. I've just put a list of very high, and moderately high purine-containing foods there because it can be a little bit difficult to get a good list. And people very seldom eat that, and people with gout should never eat anything from the very high or high categories, and take moderate amounts of that. It's useful to tell patients about things like spinach, asparagus, and lentils, as well as oysters, which everybody knows about. So by far the commonest drugs in practice is low-dose aspirin and diuretics, and especially the thiazides. I've mentioned chemotherapy, anticoagulants. In preparing this talk, I looked at the literature to see what studies there were on anticoagulants and gout, and I couldn't find any. And I've been recognizing this for 10, 15 years. It's because I'm very old. That people have a pulmonary embolus or develop AF or something like that, and they started an anticoagulant, and about 6 months later they start getting gout, and the gout can be very difficult to control. So I've always thought that, I know we all lose small amounts of blood into our gut, and if we go for a run we're going to lose more. And then you start on an anticoagulant, it's just going to increase that blood loss slightly. And I do see patients with this problem who actually become slightly anemic. And then the blood is broken up in the gut, and you get that massive purine feed, which can be quite episodic, and therefore your uric acid levels will be going up and down. So in those guys, I actually aim for a slightly lower uric acid, about 0.3. because there's going to be this episodic levels. And that's why your transplant patients get gout, and occasionally you may have a patient with TB and diagnose their painful swollen knee. So what's good? There is now good study evidence for all those. Dairy products are uric as uric. Who would have ever thought of that? There they are. And then if you've got a choice of what drugs to use, you may want to favor calcium channel blockers, losartan, atorvastatin, and Will might want to start his hyperuricemic psoriatic patients on leflunomide. I've actually never used leflunomide for that reason, but anyway. Leflunomide actually causes weight loss. So on average, patients starting on leflunomide will get 4 kilograms of weight loss in the first 12 months, and it may have something to do with their uric acid as well. So let's summarize hyperuricemia. Normal level is 0.42, but that's a supersaturated solution. For our gout patients, we don't want supersaturated. We want less than 0.36. The higher the level, the greater the risk of gout and renal damage. You should measure the uric acid in the intercritical period. So when the patient is well, about 40% of gout patients will drop their uric acid during an attack. And in my experience, the worse the attack, the more joints involved, the more the uric acid drops. Uric acid levels may be increased by diet, drugs, and ethnicity. and we can prevent gout and improve renal function by lowering it. So a 49-year-old man with a history of psoriasis and hypertension, but otherwise no significant past medical history, returns from Fiji and is woken early the next morning by intense pain in the right ankle. You're a busy GP. You can't see these people at the drop of a hat. So you see him the next day, and although hobbling, he says it was actually worse the day before. The ankle's red and swollen. He had a similar episode 3 years earlier, and that settled without any treatment because he couldn't get in to see you. You were far too busy in a few days. An urgent uric acid 0.46, and the x-ray shows no fracture but considerable soft tissue swelling. What's the diagnosis? This is a talk on gout. So, we all think he's got gout, don't we? Yes. Anybody think he hasn't got gout? No. That flying back from Oz or Fiji or wherever and waking up the following morning with gout is absolutely classical. It's makes the diagnosis almost. So
why did they get it after flying?
Well, you might think because they've been drinking too much on holiday and things like that. But actually, I've seen a number of patients who get it when they fly to Oz as well. And they wake up there and the holiday's ruined because they can't walk for 4 days. So it's quite possible that the slight drop in atmospheric pressure in the cabin causes a release of crystals and gout. So we think it's gout, but how do we know? So the American College of Rheumatology, who are fantastic people for doing things scientifically, say you can demonstrate the crystals in synovial fluid, great, but that in the best of hands, in the best of labs, only has a sensitivity of 80 to 90%. So absolutely specific, but sensitivity problems. You can prove if you see a tophus and you aspirate that and show that that's got uric acid crystals in it, that's gout. Or you can use 6 of 12 clinical criteria, and we'll come to that. So just because uric acid looks so beautiful, I'll show you 2 pictures. That's what it would look like if you stuck a needle, and I use a green needle and put 1 or 2 mils of normal saline in it and move it around in the tophus and aspirate a little bit, put it on a slide and send it off. Now, these guys have got fantastic microscopes. That's not what it looks like in your local lab. And then this is what it would look like if you aspirated it from a joint. And sometimes you actually have to look for 3 or 4 minutes to find a single uric acid crystal, and a single uric acid crystal makes the diagnosis, but you've got to be sure. In the old days, we used to say that it had to be an intracellular, negatively birefringent needle-like crystal, but now just see it in the fluid and it's the diagnosis.
Is this still done just by visualization?
Yep. And that's one of the problems. I mean, some lab tech in a lab 100 miles away from me, 70 kilometers away from me, might not be as interested in finding the uric acid crystal as I am. So in the old days, when we still had our own hospital lab, I used to go down and look at my own slides, but now it's done in the next town. So it's one of the problems with sensitivity. So the ACR clinical criteria, and this is very carefully statistically worked out. So if you've got 6 out of these 12, then you can say 95% you've got gout. So I've put an asterisk next to those that our patient had. The maximum inflammation was in the first 24 hours. He's had more than 1 attack. It's monoarticular. There's redness over the joint. The first MTP is involved. In men, the first MTP is involved in 80% of first attacks. Women are different, and if it's a unilateral MTP, then that's even more likely. So unilateral tarsal joint attack is not that common, but it's very typical of gout and not of other conditions. Seen as suspected tophus adds to the likelihood. Hyperuricaemia, asymmetric swelling on x-ray, so that's not something I would have intuitively put in there, but it comes out in the stats. Subcortical cysts on x-ray are very suggestive. They are not diagnostic, but if you see them, you're thinking, could that be gout? And a negative culture from synovial fluid, obviously, because one of the important differential diagnoses is an infected joint. Psoriatic arthritis is the commonest differential diagnosis that you worried about, or reactive arthritis. So because people talk about it, I thought I should put the stages of gout on a slide, and that's them. I see it more as a story of gout. So I told you that we increase our uric acid at puberty, and then we have a long period of asymptomatic hyperuricaemia, and then we start getting acute attacks, and acute attacks are about twice as painful as childbirth, but they self-limiting even if you don't treat them, and they will slowly get worse. They will last longer. They will spread to involve other joints. They will start to involve multiple joints, but they'll still get better, and then there'll be a phase where the patient is fine. And then they can start to sort of run into each other and affect joints that we don't commonly think of as being gout joints. So hands, shoulder, and eventually people start to develop tophi. Could you do that all? Thank you. Okay, and then you start developing tophi in the kidneys, in the eyes, in heart valves. I've seen a paraplegic gentleman because of sheets of uric acid deposition in his lumbar spine, and so on. So it's kind of progression rather than being different stages. So I just wanted to show you a couple of typical radiology views. This is the first MTP, and over here you can see a large deep erosion with this overhanging spicule of bone there. So that is absolutely typical. If you see that, then that's gout. So rheumatoid arthritis will bite the end of the joint off there. Gout erosions are away from the joint line, and they're big and deep. And this is exactly the same joint, but turned the other way. That shows you the same finding there. Okay, so as I said, there are sensitivity problems with aspirating joint. Can I just ask you to put up your hand if you regularly stick needles into joints and send them off for uric acid crystals? Okay. So the kind of new kid on the block is dual energy CT, and what's done here is to use X-rays of different kilovolt strength and get the signal back from both, and then your computer does something magic to come up with a ratio that can extremely accurately identify a number of different chemical substances. For us, we're interested in uric acid, and by convention, uric acid has been designated as a light green on this procedure. So it's up to 90% sensitive. The reason that it's not 100% sensitive is that you need enough uric acid to actually see. So you can get gout with very fine layers of crystal deposition that are beyond the CT picking up. So early disease, it's not so good, but if the patient's had the disease for a couple of years, then you've got a chance of getting it. If any of you are interested in reading more about it, this is some guys from the Mayo Clinic, and the Mayo Clinic writes, I don't know, people from the Mayo Clinic write such really nice clinical papers, so it's a really good read.